Senator Murphy.
Thank you very much, Madam Chair, and thank you for all of the hard work that you've and the ranking member have put into this legislation. As both of you stated at the outset, there is loads of good bipartisan policy inside this package. I was going to offer an amendment today. Essentially is the TREAT Act, which is a bipartisan bill that Senator Blunt and I have been working on throughout the pandemic, but I will not offer it today in the hopes that I can continue to work with both the senator and the ranking member on its substance. Its substance is fairly simple. What it would say is that any healthcare professional in the country who is licensed in good standing to care for patients from any state during the course of the pandemic can treat patients in states other than the one in which they are licensed in. And obviously this is really important in a pandemic for two reasons. One, you have a lot of healthcare professionals, especially during these surges, traveling. You have nurses traveling. You have physicians who are going to places in which the cases are the highest, and they have run into, over and over again, these barriers of state-by-state licensure. Second, you have a lot of people living in places temporarily that are outside of their regular treatment area. So, for instance, you had a lot of college students who maybe had a mental health professional on campus who can't see them when they are learning from home. And so Senator Blunt and I have narrowly tailored this legislation to be exclusive to the current pandemic, but I would argue as we're getting ready for the next pandemic, we need to talk about this issue of the barriers to treatment presented by state licensure. So I look forward to continuing this discussion with the committee. Just one final comment. I was glad to hear Senator Burr issue a challenge about making sure that we get more good information to this committee. I share that concern. But one of the issues I think left undone from this legislation is the fact that CDC itself doesn't have enough access to information in order to compile it and provide it to us. Inside a national emergency, CDC has the ability to get real-time data regarding vaccinations and infections. But when that emergency is gone, CDC has, I think, surprisingly limited ability to get data from states. They essentially have to enter into 50 different agreements with states to get information from them once that national emergency is lifted. And even when the emergency is gone, we are still as a committee going to want to have information, for instance, on the continued efficacy of the vaccine or the emergence of new variants. And it's just highly inefficient for the CDC to have to do this on a state-by-state basis. We could give them some limited but reasonable ability to get that data outside of the public health emergency. I think that we weren't able to find common ground on that given our short time frame, but it's something that's essential if we as a committee have an interest in getting that data. So again, I thank the chairman and ranking member for entertaining both of these conversations, and while I won't offer Murphy Amendment number 1 here today, I look forward to working on these two issues. Thank you, Madam Chair.
Madam Chairman, could I say to Senator Murphy, we're committed to work with you to try to find a resolution. As you know, currently in emergencies between state compacts, we recognize the credentialing outside of the state, and Medicare and Medicaid also recognize the credentialing outside of a state. So the framework is already there. It's just a question of closing the gaps a little bit. And to your comments on the CDC, I agree with you. But I think all of us need to realize that the surveillance that is suggested exists does not exist. Surveillance is the best source of data that's out there because it gives you slices from different angles of what you're faced with. And the CDC today is only relying on hospital data that's reported to a county, that's reported to a state, that's reported to Atlanta. If all we want is a supercomputer to source data that's old by the time we get it, then that's invaluable. But CDC has to learn how to take surveillance and use technology and take foreign examples and foreign data to incorporate in their modeling. That's not done today. If it is, then share it with us. But on the surface, it doesn't look like that's what drives their guidance. So it's a much more complicated thing, I think, than just saying if you only required this data. If the data's old when they get it, it really doesn't serve us any purpose in a real-time threat. So I look forward to working with Senator Murphy.
Thank you. And Senator Murphy, I know you've withdrawn your amendment, but I think this is an important issue. I think COVID-19 really put a spotlight on concerning challenges around our healthcare workforce. I look forward to continuing to work with you on that.